is involved with maintaining the patella in its track. The VMO, right? So that's this medialis obliquus. Okay? What's our next step?
Valgus stress.
Valgus stress on the knee. You have the patient lay on the back. You can do it seated. You can do it laying down, however you want to do it. In fact, yeah, this is cool. Now, lay down. Sit up. Come on over.
Roll over.
There you go. Yes, roll over. So it's probably on the right side. Okay, so we'll valgus stress. We'll start on the left one, bring it up. I'm not sure where you can see better. If you need to move, feel free to do that. We're just going to take the knee into full extension. We're going to add valgus stress by moving his ankle lateralward and with the fulcrum in the lateral side of the knee. Then, if that doesn't cause any instability, we're going to then bend the knee a little bit and do the same test. Remember how we did that with the elbow. So we'll go over to this one. Same thing. Keep it nice and straight. And I like to do it like this, but that's okay here. If you just do it like this is sufficient, and you can bend this like this. Okay? We're looking for not just pain, but instability. So with these instability tests, I want you to say, well, you know, I have increased movement, abnormal movement, something like that. And the other one, of course, is the opposite, which would be your varus stress, right? We'll bring this up like this, push this over, bend it. Again, looking for that instability. Right? Here. Okay. And that would be lateral to lateral.
Apley's contraction.
Apley's contraction. I mean, this again is for instability. Apley's distraction. Apley's. Okay, so again, the problem is on the right side. You can start with this one, and we're going to pull this up, and we're going to turn it. Right, whichever way. So I have external tibial rotation, and what am I testing? Which collateral ligament?
No, medial.
Medial. That's why they're going to say it on the boards. They're not going to say the heel goes one way or another. Okay, and you have to return it to neutral before you let it go. Lift up and turn it, so on and so forth. Restore it to neutral before you do it. We can go over to this side, and again, we're looking for laxity, pain. Okay, internal tibial rotation is the lateral collateral. Lateral tibial rotation is the medial collateral. Okay? And then compression is at the next one. We're just going to press down like this. I think this is the best way to come over and hold on to it like this. This way doesn't work so well. Pushing onto the patient's foot. I don't like to push on patient's shoes. I don't like that. So here, turn, and again, external. It's the same exact mechanism. Whichever way the heel is going, that's the meniscus that you're testing in this case. Okay?
Bounce home.
Okay, bouncing home, that patient's fine. And we're looking for meniscus. It could also be osteochondritis dissecans, right? So you're going to take the patient's knee up, you're going to drop it. Boom. Now we're not slamming it down. He's trying to help me. Just let it go. Just let it go. That's all you got to do. Okay. If it didn't lock out and it stays bent somewhat, doesn't give you that nice end feel that you're looking for, that would indicate there's something in there in that joint, probably meniscus. And again, listen to the case history. You know, and your X-rays will help you a lot as well. If it's OCD, you're going to see that on the film. You won't see the meniscus on the film.
McMurray sign.
Okay, McMurray's, that's another one that, as far as looking for meniscus, we're going to, since the right one's the problem side, we'll pretend we do it on that side. Generally, what we used to do is we would turn the heel this way, and this, whichever way the heel goes is the meniscus that you're testing, okay? And this is the way we used to do the lateral meniscus. We'd bring this up, we'd add this, and we would do this. You can see I'm compressing the lateral meniscus. What I understand now is they want you to keep the heel, and they also want you to add the valgus stress. I mean the varus stress. Okay, this is the valgus and the varus stress on both of them. Okay. So, and if you're doing the medial meniscus, it's like this. You'll add the varus stress, but then you'll also go back and add the valgus stress.
This way.
That's when you have the patient stand up. coats are a little cuter than you, and you're going to dance with them. Dance looks kind of cute. Just like this, sir. Good. And that was on the left knee, now try it on the right one. Good. Now what we're going to do is, that doesn't cause any problem, and then go a little lower. And twist on the twist. Yeah, twist it. There you go. Yeah, I remember going out with a buddy of mine. He said, "Come on, I want to ask this girl to dance." I said, "I can't dance." He said, "Yeah, ask the girl to dance." I said, "Yeah." He said, "I want to dance with her girlfriend." I said, "Okay." I went up there on the floor, did some, and the girl looked at me and she said, "Thank you." But my buddy got to dance with her girlfriend. That's what he wanted. Sorry.
Take one for the team, that's a good wingman.
I did it for my buddy, that's all there was to it. I tried to up there, I thought it was pretty good. She did not think I was doing very good. She said, what's our next test?
Patellar grinding test.
Patellar grinding. Yes. Patellar grinding, that's also known as Clark's test, right? And this is the one that's no fun. Everybody tries to do. What we're going to do is we're going to do it on the uninvolved, and we're going to do the involved side. We're going to just push that kneecap down, right? Push it down, and we're going to have the patient contract their quads, right? If they can do that, and you're going to not let it, you're not going to let it come. If they can hold it there, then that's pretty good. It's supposed to be a lot of severe pain underneath there. Again, probably chondromalacia patella, some type of telefemoral arthritis. Something's not making them happy. Probably the test isn't making them happy. Now that is patellar grinding. Fichets is where you're grinding it, you know, so or fichettes, however they say that. Is that the next one, isn't it?
Fichet,
yeah, that's when you're going to just press down, you know, do the uninvolved side, ask them if it causes any pain, grind it in. Does that cause you any pain? And you grind it in, you ask them where it hurt. Always ask them where it hurt. Again, something retropatellar. It might be fat pad, it might be chondromalacia, but something's going on back there probably. I think we have chondromalacia. But remember, there's a bunch of different lesions, and so lesions are a good answer. But when you're testing for us, we just look across the notes, so make sure you say what's in the notes. But you got to remember there's so many different things that can cause the problems with these. And patients never say, yes, that's positive. The only thing they always say is what? That hurts. And so don't automatically think because we've always told you it's chondromalacia, the person automatically has that. That absolutely would be inaccurate. What's our next thing? Allotment. You're just going to milk down all the water, and then you're going to push the patella in, and you're going to watch the patella come back out, right? Down into this femoral pouch, you're pushing all this fluid down here, and you're going to watch that come out. And that fluid wave, I think is what they call it. And it's just for, means there's a lot of swelling in their fusion. Something's causing that, some type of lesion.
Drawer test.
Drawer. And what I want you to do on this is I want you to palpate right along this tibial plateau here so you can understand this joint, because when we get you in extremity adjusting class, I want you to be able to distinguish between the tibial tubercles, or the tibial condyles and the femoral condyles when you're making your adjustments. So get used to this, okay? So what we're going to do here, we're going to stabilize and we're going to pull. And you can see it gives way some, that's okay. If it gives way 6 millimeters or more, you start to do a little stair step, that's indicative that you have a problem with the anterior cruciate ligament. And for a posterior cruciate ligament, you would see the sag sign. Remember I told you that, and you should be looking at these things on YouTube. They're very interesting. You'll just see it just hangs back there. If it's not hanging back, you can just shove this way and see if that's displacing the posterior. Bachman's. I'm going to have you move up the table just a little bit. Bachman's, we're going to bring the patient's leg down like this, and we're just going to move this back and forth. Some people stabilize here and pull this. That's fine, but the idea is to take some of the stability caused by the quads on it. So you're straightening that out a little bit, and then you're going to pull this. You can do it like this. You can do it like this. Either way, I'm happy with that anterior cruciate ligament.
Lateral pivot shift.
Lateral pivot shift, this is the one that was a little confusing, but it has to do with the way the IT band pulls here on the tibia. And what we're going to do is we're going to add some internal rotation. We're going to bring this up with valgus stress. Now, at this level right here, this is the way Susan talks about it, here, it's the, even though I'm putting stress on it, it's the IT band that's causing this to subluxate. It's causing the tibia to subluxate. And then when you do this, the IT band then shifts from taking it into extension somehow into flexing the knee. You read about it. And when this does this, it'll clunk back. It shouldn't clunk back, it just moves smoothly. But if that anterior cruciate ligament, there's a couple other ligaments that might be involved with this, but if that's not intact, when you just straighten this out, it's going to go clunk back into place. Clunk. So I'm adding valgus stress, I have internal rotation, and all I'm doing is going like this. Boom. That's the whole test.
Compression.
Noble compression. We're again, IT band. I'm going to compress here with my thumb, just at the femoral condyle. I like to be just a little bit proximal to compress in here, straighten this out, and the patient will say, that hurts when we're getting it closer to extension. IT band compression.
Renee's test.
IT band syndrome, I'm sorry. Renee's test, you can, for Renee, I'm going to have you stand up. What the idea is here, we just want to do the exact same thing we just did. Okay, the patient's having problems on the right side, so you'll come over here to the right side. You're going to have him put his knee up, his foot up. I'm sorry, put your foot up there. There you go. I'm going to compress same place. And I'm going to have him, okay, you want to step up there for me? Okay, good. Okay, keeping pressure. Or if you don't want him to step on something so high, or if you don't think it's stable, you can just hold pressure here. And even use two hands if you like, and just have the patient do a squat. There you go. Straighten up. See if it's causing any pain.
Slocums.
Slocums, that's rotational anterior. Yes. No, face up, I'm sorry. Anterior lateral rotational instability or anterior medial rotational instability. That's all I want you to know. Again, so what we're going to do, we're going to do internal tibial rotation. This is for anterior lateral tibial rotation. Okay, you can also have a lateral cruciate. But primarily what we're doing in here is we're taking a bunch of different ligaments. Whenever you're pulling like this, even with the drawer test, don't pull down here on the patient's calf. Get up here above the calf and pull. Okay, this would be for anterior lateral rotational instability. This is anterior medial rotational instability. So you're getting a little more of the medial collateral, etc. But you want to remember the primary AC. I mean, anterior cruciate.
Apprehension.
There's a bunch of them.